So welcome to the Intervention and Treatment for Suicide Risk abstract session of the U of M Injury Prevention Suicide Prevention Summit. I am Dr. Alejandra Ringo, and I'll be moderating this session today. Thank you all for joining us. We're very glad that you're here. As a reminder, this session is being recorded and only the presenters and moderators are visible and allowed to turn on their audio and video. If you have any questions for our presenters, please ask by typing them into the question and answer box on the right side of your screen at any time. Be sure to indicate who your question is for by including the presenter's name at the beginning of your question. You will notice on the right-hand side of your screen that you can toggle between the Q&A for this session and also for the main event. When asking the questions, please type them into the Q&A for this session. The Q&A will take place after all the abstracts have been presented, but we encourage you to send in questions throughout the session so that we can have a chance to review them. We will answer as many as time allows at the end. Our presenters will have 5 minutes to present their abstracts. We will share their slides while they are presenting, but you may also access their abstracts on the Center's Summit webpage. The link can be found in the hop-in reception area. There are 3 other abstract sections occurring at the same time as this one. As much as we would like for you to stay here and listen to these great presentations, please feel free to jump between sessions. Recordings for all sessions will be released in the coming weeks. Now please join me in welcoming our abstract session presenters. I will introduce everybody now so that there's no interruptions in the flow of the presentations. Please welcome our first presenter, Dr. Bertrand Berger from Milwaukee VA Medical Center and Medical College of Wisconsin, Milwaukee. And Daniel Buttry, President and CEO of the War Memorial Center in Milwaukee. Our second presenter will be by Brigham DeFrazio and Lauren Walker from the Covenant Healthcare. Our third presenter is brought to us by Dr. Cynthia Ewell Foster here from the University of Michigan Department of Psychiatry. Our fourth presentation will be brought to us by C. Kenzie Corbin from the University of Michigan Medical School. And our last presentation will be by Sarah Clark from the Susan B. Meister Child Health Evaluation and Research Center Department of Pediatrics here at the University of Michigan. Presenters, when it's your turn, please turn on your audio and video and then turn them off after you're done. And we can begin.
All right. Well, thanks. We're happy to be here to talk about our task force on veteran suicide prevention. So I'm Bert Berger, and I'm a director of the mental health division in Milwaukee. And as part of that, I've been very involved in suicide prevention with veterans, worked on an inpatient unit for many years, and so directly involved in working with veterans. So I really wanted to set up something that we could start addressing the problem with veteran suicide. And I started this in 2019, a community task force. The VA tends to be fairly isolated and doing their own thing a lot of times. So this is our outreach to the community and to develop something where we can really outreach to those veterans, because a lot of them don't come to the VA. About 2/3 of them seek services elsewhere. So we need to connect with the community. So with that, I developed a task force with Dan Buttry. Next slide, please. And with this, we've following really the President's roadmap to empower veterans and end a national tragedy of suicide, which is the PREVENTS model. In that basic strategic framework involves communications, culture change, lethal means safety, partnerships, workforce and professional development, state, local, community action, engagement, research, policies, programs, and then seamless access to care. So with that, our coalition was really developed into 4 different sections. One is to look at public health messaging to try to reach all of people that are affected by suicide. Some strategies for those that are trying to outreach to those that are veterans may need help, but not necessarily having mental health issues. And then the indicated strategies are those for the few, or our clinical action area. For those that have mental health issues and really need help from a clinical aspect. And then we need to test and look at new interventions and policies and ways to see what interventions work. So with our task force, we really had some great outcomes. And the next slide, Dan Buttry can talk about what we did with public health messaging. Just from really working together and from his War Memorial Center, it's really been inspirational to see what we can start doing. So off to you, Dan.
Thank you, Dr. Berger. It's a pleasure to be here today. As Dr. Berger referenced, our collaboration, the War Memorial Center in Milwaukee, is a 501c3. It is a building that was built in the late 50s to memorialize World War II and Korea vet who were killed, but there's also has a unique structure. There's offices here for the USO, the paralyzed vets. We do a lot of events and activities. And my background, I was a combat commander in Iraq, but also as a reservist, and I had a career in the media marketing industry, as well as an engineering space. So when Dr. Berger reached out with the task force, we were able to collaborate on the networking, the statewide engagement of veterans around the state, and then also my background in working with broadcast media marketing. We took a $4,000 seed funding, as you can see, and those of you who've worked in broadcast, advertising, et cetera, or in that space, understand that's not a large amount of budget to work with. However, what we found in working with, in this particular case, our local iHeart media group, they were very interested in assisting and helping with the larger discussion of suicide prevention, veterans, the family, and the network. And so really what they did is they took a combination of their broadcast and their digital footprint. iHeart, if you're not familiar, is one of the largest media companies in the United States. And they really have a real dynamic capability to do what they do. And as you can see, we did a heavy campaign with streaming. We were bringing them back to the Be There Wisconsin, BeThereWis.com site, which Dr. Berger and the task force set up. So it was the direction of where we brought them, and you can see some of the quantifiable data that we were able to deliver. And on the open percentage rate, that's a pretty high percent. What we were able to do were identify emails that were veteran emails in the state through the iHeart program, send them information. They were able to engage, click through, and come back and interact. And so when it was all said and done, there was a market value, a value added thrown in of just under $25,000. So that seed money of $4,000 really did gain a significant amount of market value, and a number of interviews for Dr. Berger to get out and some of the other health experts to talk. And so, yeah, it was a great partnership to work with the VA and the task force. So bringing that to other projects that are tied to this, Dr. Berger, I know you've got a few items to finish up on.
Yeah, so our outreach area then was also able to partner with public messaging component, and we brought together our 211 phone system, which is for psychosocial support and throughout the state of Wisconsin. And one of our other partners, Center for Veterans Issues, developed a phone app to partner with 211 so that veterans can use this phone app and then connect with 211 systems as well as the phone app system. So that's another aspect of what we do. And then we did press releases for that project. In doing similar things in our clinical area, we're looking at transition of soldiers from the military into civilian life and how we can connect with them. And we also work very focused on firearm safety or firearm storage outside the home and our research end of things. So next slide. And our goal is to continue with these projects and continue to develop in collaborative ways to increase the cultural changes that we can make around veterans as well as the entire community around suicide prevention. So, so thank you for listening. And this is our example of a task force developing measurable goals and projects.
Hi, I'm Laura Walker. I'm the Trauma Education and Injury Prevention Outreach Specialist at Covenant Healthcare.
and my name is Bregan DeFazio. I'm the Clinical Outcomes Nurse Specialist for Pediatrics and Pediatric ICU. We'd first like to thank the University of Michigan Injury Prevention Center for hosting and for this opportunity to share our project.
We'd also like to acknowledge the Saginaw Police Department and Covenant Healthcare Foundation for their support in donating gun locks and medication lock bags for our patients. As we've all learned today, suicide is the second leading cause of death for adolescents. Prevention and postvention are key to reduction of attempts and completions. Covenant Healthcare saw a significant rise in pediatric suicide attempts requiring inpatient admission. In 2020, the number of admissions tripled from the previous year, totaling 67. A decrease in the mean age was also noted from 15.5 to 14.4. The readmission rate from suicide attempts or self-harm averaged 19% over the last few years. In 2020, prior to implementing CALM counseling, the rate increased to 29%. A quality measure from the Center of Excellence on Quality of Care Measures for Children with Complex Needs states that children admitted to the hospital for self-harm or suicidality should have documentation in the medical record that their caregivers were counseled on how to restrict their child's access to lethal means in the home prior to discharge. As of July 1st, 2020, Covenant Healthcare has implemented this quality measure. Social workers or bedside nurses assess lethal means in the home upon admission and then collaboratively discuss a safety plan on how to restrict access to these means. A gun lock and medication lock bag are given to the family post-discharge. A follow-up phone call is provided to the family to assess how they are following through with this plan.
Quantitative data was collected retrospectively on pediatric patients admitted for self-harm and/or suicide attempt from the last 3 years. Data included age, gender, method, psychiatric history, including previous ECC visits or inpatient admissions, and disposition. After implementation of counseling on restricting access to lethal means on July 1st, data collection continued with the addition of tracking which caregivers received counseling. A survey was also conducted in the form of a follow-up phone call to assess safety in the home post-discharge.
6 months post-implementation of the CALM counseling, the readmission rate dropped to 8%. 83% of our parents or caregivers received counseling on restricting access to lethal means. 81% of those parents or caregivers have been able to be contacted for a follow-up phone call.
Next slide, please. The role of suicide prevention in the acute care setting is crucial. Having discussions with the child and parent or caregiver can help bring awareness and acknowledgement of the situation. A multidisciplinary approach helps enable the caregivers to promote a safer environment in the home. Often the shock and reality of suicide attempt may inhibit learning and retention of information in the acute care setting. So utilizing an interactive approach, even post-discharge, allows the caregiver the opportunity to receive support and information from a variety of resources. Providing CALM counseling has increased parents and caregivers' knowledge about the association between access to lethal means and the role it plays in suicide prevention. Our team at Covenant Healthcare is dedicated to these patients and their parents, and while it is reassuring to see the number of readmissions decrease, we recognize there is more work to be done, and this is only the beginning. This concludes our abstract presentation. Thank you for your time and attention today.
Hi, everyone. I'm Cindy Ewell Foster, and I'm going to be talking with you today about some work that we have been doing in conjunction with the Michigan Department of Health and Human Services and our Psychiatric Emergency Service at U of M. I'm waving at Laura and her team because I got to know them related to this work as well. This work has been funded by Michigan's Garrett Lee Smith Youth Suicide Prevention Grant, so I just want to say thank you to SAMHSA for our funding. I'm going to start with some background for you. We know that rates of youth presenting to emergency departments for suicide-related risk are continuing to climb and have almost doubled in the past decade, and that our emergency departments have a really critical role to play as a safety net provider. The Zero Suicide Framework provides guidance and best practice approaches for clinical care in our healthcare systems. But despite widespread dissemination, there really is very limited empirical guidance about how to adapt zero suicide protocols to ensure that they're developmentally appropriate and family-centered for youth and families presenting to emergency departments. So the study I'm talking about today is just one small piece of a larger project that's focused on improving the quality of care for kids and families seeking emergency care for suicide risk. Next slide, please. So those of us who identify as child clinicians know that working with youth and families is unique and different than working with adults. For example, we know that youth outcomes in mental health treatment are improved when their parents are engaged and supporting their progress. We also know that our most promising interventions for youth suicide risk have a family component. However, many youth who are at risk for suicide report high levels of family conflict and parental psychopathology that can impact parents' ability to implement discharge recommendations for their kids. So in this study, we were really interested in learning about the extent to which really highly trained group of clinicians in a lifespan psychiatric emergency department felt comfortable and knowledgeable working with young people, learning about the strategies they were using to implement brief interventions in the ED, and whether we could improve not only their perceived competence for working with kids, but also their skills to be more family and youth-centered. So the participants in this small pilot trial were 29 clinical social workers who work in our emergency service. They all had experience conducting risk assessments and safety planning. They completed an online de-identified survey that is based on the Zero Suicide Workforce Survey with some modifications to assess pediatric content. We were trying to maximize the number of people who participated. So the training was conducted in 2 staff meetings, and we did not collect identifying information for providers. We didn't link their pre and post-test surveys. The training content was developed using expert consensus guidelines, consultation with senior clinicians, and some of the quantitative and qualitative data we've been collecting from families in PES telling us about how we could serve them better. Next slide, please. So I'm going to go over some of our results and apologize for this busy slide. You can see that clinicians were rating on a 5-point Likert scale. At baseline, staff in this lifespan emergency department reported significantly more confidence in their ability to work with adults than in their ability to work with teens and younger children. You can see that these staff are already engaging in really high levels of these recommended practices. So shout out to our wonderful social workers at PES. But we were able to see some improvements over time in some of these recommended practices. So you can see some significant differences in terms of the frequency with which staff were assessing and considering family factors and making decisions for kids, the extent to which they were providing emotional support for parents who were going through a difficult time bringing their kid to the emergency room, improvements in working together with the family to complete the safety plan or helping the youth to come up with coping strategies for their safety plan. Obviously, some areas where we didn't show difference. One in particular, no change in staff referring parents to their own care. Next slide, please. So there are lots of limitations to this small pilot trial. We really see it as a first step. But our team feels very passionately about how critical it is to study the adaptation of approaches developed for adults in pediatric settings. We have a paper coming out soon that really speaks to how important this is, suggesting that parents, when we can help them to feel more comfortable and confident, they really are able to implement better when they leave the emergency department. We're really fortunate to be able to continue to disseminate these trainings and others through our growing Youth Pediatric Suicide Prevention Emergency Department network that's funded by our current SAMHSA grant. And if you're interested in learning more about that, I hope that you will reach out to me. Thanks for having us today.
Hi, good afternoon, everybody. My name is Keith Corbin, and I'm a current medical student here at the University of Michigan. And today I'm here to talk to you about M-Home Peer Support Advocacy. This is a student organization whose main goal is to make mental health accessible to medical students. This program was originally started by a medical student, Claire Collins, 4 years ago, because there was actually no system or protocol in place to offer mental health resources to medical students here. Next slide, please.
Hi, this is Sarah Clark. I'm at the Cheer Center over in the medical school. I'm also at part of the Csmo Children's Hospital National Poll on Children's Health team. And we'll be talking about parent views on school-based peer support programs. Next slide. So this is our Csmo Children's Hospital National Poll on Children's Health. Is a mouthful, so we call it the MOT poll. And the MOT poll has been around since 2007. It is as you can see, a recurring online survey. We field it about 3 times a year. Each poll includes 4 to 5 topics, and we generate a monthly report. We like to think about this as a snapshot in time. And so we're not doing a deep dive on any one topic. What we're doing is doing a general kind of layperson snapshot of what a national sample of parents might think about a particular topic. And we can target the questions within each fielding to parents based on the age of their kids and other characteristics. Our survey, our vendor for the MOT poll is the Knowledge Panel. We like that because it's not an opt-in panel. It is a scientific, address-based sampling mechanism. They have about 40,000 households across the United States, so they are able to draw samples for us that really reflect a national representative group of parents, and then they provide post-stratification weights that are matched to the census. We don't interact with the subjects at all. So this data I'm going to present to you was fielded in August of last year, and of the 2,000 and some respondents, this is based on about 1,000 who had children or teens, 13 to 18 in their household. And they all got a common intro. When teens have problems like depression, eating disorders, stress, or anxiety, they often talk with friends rather than adults. But in some cases, teens don't talk with anyone at all. Training teens to be peer support leaders is one way schools can help students with mental health problems. Peer support leaders are carefully selected and trained not as counselors, but with skills to be good listeners, encourage teens to seek help, and alert an adult if signs of suicide or other serious problems are identified. So that's really all parents had to go on, unless they were familiar with a program like this. So turning to results, 3/4 of parents did agree that having peer support leaders at school would encourage teens to talk, so they get the rationale. If you look on the right in that yellow square, 33% said they definitely support having the program. Notice that only 7 said they don't support it. I would just note that 28% of parents said that their teen's school had some kind of peer program, and these parents were twice as likely to say that they definitely support having a peer support program. Parents did say concerns in that kind of greenish box in the middle, and these are all the things that you would expect. Confidentiality, how would it work with identifying who's in crisis, and how they get to a responsible adult, and can teens even be trained to provide this kind of support? On the bottom in orange is parents' views on, well, how would it work for their own team to serve as a peer support leader? Most parents did agree that if their teen wanted to, they would support that decision, and it wasn't different for middle school versus high school kids. But parents saw both the benefits of serving as a peer support leader, understanding other people's challenges and developing leadership skills and giving back to the community, but also concerns that really made a lot of sense to us. And so as we go to thinking about what does this mean, parents really get, even with that minimal introduction, parents get the rationale for these kinds of programs. They are hesitant to say they definitely or strongly support something because they still have questions. But questions don't translate into lack of support. Their questions make a lot of sense, and they recognize that it has pluses and minuses. So our overall conclusion is, if people are trying to initiate or advocate for a type of program at a middle school or high school, they should not assume that people's concerns or questions are roadblocks to implementing. They just need to take time to answer the questions, describe the structure of the program, and make people feel a little more confident that things are in place to ensure that both the teens seeking help and the teens providing help are well supported by responsible adults. Thanks.
Thank you all for a really wonderful set of presentations. And I received some feedback that I was getting feedback at the start of this presentation. So I hope that it sounds okay, but if somebody would let me know if they are receiving any feedback at this point, that would be fantastic. And we have just a few moments for some questions. And I think we will start where we ended with Sarah Clark. And I'm going to ask all of the presenters just to turn on their mics and to turn on their video and their mics when it's time for a question. And we'll get started. So like I said, we'll start with Sarah Clark for our first question. And we were wondering if you found any demographic differences in parent support for the peer program.
We did mothers more so than fathers in terms of support, and compared to white parents, Latinx parents in the sample were about twice as likely to express support. There really were not a lot of standout differences in who did not support that program. Maybe a little bit with a person who was not employed at that time, but it wasn't as strong a finding.
Okay, and this one was for Dr. Yule Foster. What are your next steps to apply what you've learned in developing the staff training?
For asking. So I alluded to this at the end, but we're really very fortunate. We've been funded by SAMHSA again with our Garrett Lee Smith grant. And part of that work is to translate what we've learned in our partnership with PES to other general medical emergency departments across Michigan. And so we're currently working with 2 emergency departments. So we bring 2 EDs in a year to join this learning collaborative. We have a wonderful team at PES who's really providing technical assistance and mentorship to other emergency departments so that they can really be sure that the brief interventions that they're doing are best practice and tailored for young people. So we're really grateful for this opportunity. And if anyone's interested in applying to be part of the network, please reach out to me. There's just an easy RFP, just an application process. Thanks for asking.
Thank you. And I'm just seeing some questions on the Q&A, and I thought that I had an internet lag, and that's why I didn't see Kenzie Corbin's presentation, but it sounds like there was some sort of issue. And so I would love to invite you for our last minutes of our Q&A to finish your presentation. I'm sorry about that.
Thank you. That's okay. My internet totally cut off. So I apologize to everyone for that.
Go ahead.
All righty. So wait till the presentation gets back up, but just as an intro again, so I'm speaking from the medical school. And so with M-Home Peer Support Advocates, our main role is to support medical students with mental health. And basically we're acting as referral agents to be able to guide medical students to knowing where they can get that help. And our main role is actually in 4 different methods. And so I know the slides, I'm not sure if they match what I'm saying right now, but our 4 main methodology of doing this is with programming and events, which I'll talk about in a little bit, as well as social media, and then having 24/7 support. And so in the beginning of each medical school year, we present to the incoming first-year medical students who we are and what we stand for. And so on our website, we actually have a list of all of our current advocates with their biographies and a photo. And important to keep in mind that all of us advocates are current medical students. So this is a peer program similar to Sarah's, where it's peers assisting other peers with their mental health. And so current medical students can then go on our website and select a peer support advocate that really resonates with them, and then individually send them a message. Additionally, we do have a 24/7 pager number. And so I'm on pager duty right now. So if anyone wants to test it, you can page 37586. And basically every week there's a different M-Home peer support advocate who covers that number. And so if any medical student is in crisis or is in need, there's someone there to help immediately. And so it's nice that we have that on-call system. And so again, our role is to act as a referral agent. So if somebody at 3 a.m. is having a crisis, they're able to page or email us, and we're able to connect them with the resources that they need in that moment. Next slide, please. And additionally, we do have our social media. And so on each of these slides, you're able to see our handle. So feel free to follow us on Twitter or Instagram. And we do post weekly Wellness Wednesday posts and Fact Friday posts, as well as share stories that basically just offer the public, by and large, some great and creative ways on how to stay mindful, how to bring wellness, and just other ways of looking for the signs of suicide. And so specifically, I wanted to just draw attention to a few of our most successful programs and events. So over the past 2 years, we've had about 25 events longitudinally. We definitely had to shift gears when COVID did happen. So it made things occur a little bit more virtually and creatively, but we started having a weekly COVID coffee virtual hours, which enabled students just to really interact with each other when we were kind of all scared and spread out in this country. Additionally, one thing that we're working on right now is a Resiliency and Vicarious trauma workshop that's being led by Karen with the Grove workshop. So basically, Karen is a licensed psychotherapist and yoga instructor, and she's developing a 4-part series specifically for our medical students that really deals with trauma that we see vicariously. So as being a healer, as being a student in and out, especially on COVID floors or on trauma floors, and how we can learn to turn off that when we go home and then wake up and do the same thing the next day. Because there are such unique stressors of being a medical student, and this is a very vulnerable population with mental health, a lot of our programming is working as sort of a preventative measure. And we want to make sure that students know that they have the support and resources, and also that this is not going to affect their academic outcome. Unfortunately, there is a big thought process that students who do seek mental health, especially here at the university, that somehow that will be then on their record as they apply for residencies and so forth. So we want to basically let people know that they are capable of getting support, and we do have support for them. Additionally, another program that we did was provide an anatomy workshop. And so that allowed first-year students to really come together and share some of their maybe thoughts, fears, anxieties about the first time of going into an anatomy lab. Perhaps this was the first time that someone might have been faced with a life that was no longer alive. And so we wanted to be able to provide an outlet for these students to share their feelings and really feel that support. Next slide, please. And so just to kind of put into summary everything that we do, our main goal is to really destigmatize mental illness and normalize talking about suicide, especially among medical students. We've also made sure to really connect with other university-wide well-being efforts. And so we currently have working groups that are working to implement having specific medical school therapists just for medical students. And again, we just really want to inspire students to not be afraid to reach out to their friends, whether it's informally through our program or more formally by attending an event, and just to make sure that they're not alone. Thank you so much.
Thank you so much for that. I'm glad that you were able to present. And kind of just going off of that, Kenzie, I'm wondering a little bit about, and so are others, about the training that peer advocates get to work with other students. It would be great to hear a little bit about that.
Yeah, great question. Thank you. So we actually work at the beginning of the year with Amy Schreihart, who's one of our house officers. So she works for the medical school. And so we do various training that's kind of based in CBT, so cognitive behavioral therapy. And we're just learning about ways, again, to act as a referral agent. So by no means are we trained professionals, and we make sure that students do know that when they can reach out to us, we're then kind of the way and the advocate for them to find that licensed professional help that they do need. But we do have annual training that does occur.
Fantastic. Thank you for sharing. And we are actually at time, so just a few wrap-up things. Thank you, everybody, for joining the Suicide Prevention Summit virtually this year. And I want to thank our presenters for really wonderful presentations today. You will all be receiving an evaluation survey within the next few days, and we encourage you to fill this out to help us continue to grow and improve this event in the future. Please also fill out the evaluation survey if you need continuing education credits. We want to encourage you to attend our upcoming Ask the Expert Twitter event on Tuesday, March 30th. That will be at noon. And we'll be reviewing some of the questions that were asked during this event, and additional information on this can be found on the Injury Prevention website. And if you are not already a member of the Injury Prevention Center, please go to our website at injurypreventioncenter.umich.edu to become one and get access to our monthly newsletter with publications, updates, and events. And as a reminder, all sessions today were recorded and will be available on our website in the coming weeks. Next, we're going to take about a 10-minute break, and we'll begin the last plenary session by Dr. Keith Kumtot from the University of Washington at 4:20. Thank you all again for your attendance, and thank you all our presenters for the really important work in suicide prevention. We really do hope that you have a good rest of your day. Thank you.